evening, everyone. Welcome to our first inaugural Asia Pacific Glaucoma Society webinar.
Hi everyone, and welcome to the first webinar by Asia Pacific Glaucoma Society this year. Theme, How to Improve Adherence and Compliance to Medical Therapy. It is my great pleasure to be your moderator today. Before we get started, I would like to go over a couple of items. APGS welcomes everyone to become a member of the society. The Asia Pacific Glaucoma Society is open to glaucoma, ophthalmologists, researchers, trainees, specialists, associates, and corporations with affiliation in glaucoma. There are many reasons to join APGS, and on the screen are just a few items which we can share with you. You can register as a member by scanning the QR code below. And all APGS members gain access to all recordings of the previous APGS joint symposiums, masterclass, and webinars. On one final disclaimer, presentations are intended for educational purposes and do not replace independent professional judgment. After this webinar, you will receive a short feedback survey, and we would really appreciate you taking a moment to complete it. Only after completion will you receive a certificate of attendance. I'm sure that you will want to pose questions to our speakers. There will be a Q&A session at the end of this webinar, and you may enter your questions in the comment section. And finally, before we begin with the webinar proper, I would like to thank Firetrace for its continued support towards APGS activities, including today's webinar. Now, I would like to proceed with the speakers. I'm sorry, I haven't introduced myself. My name is Virna. I'm from Cipto Mangunkusumo Hospital, University of Medicine, Universitas Indonesia. And I will introduce the first speaker for the webinar, Dr. Yu-Chieh Ko. She will present the presentation. It is with immense pleasure that I will introduce her, who recorded her lecture on adherence and persistence to treatment as the main challenge in glaucoma, but will join the Q&A session live at the end of this webinar. Dr. Yu-Chieh Ko currently serves as the Director of the Glaucoma Service at the Department of Ophthalmology at Taipei Veterans General Hospital. Additionally, she holds the position of Associate Professor of Ophthalmology at the School of Medicine, National Yang Ming Chiao-Yung University. In addition to clinical research on glaucoma, she has been actively involved in integrating artificial intelligence into glaucoma diagnosis and the management of retinal disorders. Please start the lecture.
Good evening. I'm Dr. Yu-Chieh Ko from Taiwan. Thanks for having me in this great event. My topic is adherence and persistence to treatments as the main challenge in glaucoma. First, I want to define three terms related to this topic. Adherence is commonly used as a synonym of compliance and is defined as the proportion of pills or eye drops taken within a specific time interval. The difference is that compliance is a passive behavior in which a patient is following a list of instructions from the doctor. Adherence is an active choice of patients to follow with the prescribed treatment and taking responsibility for their own well-being. Persistence refers to the length of time during which the patient is taking the medication as prescribed. Poor adherence has been a critical issue in managing chronic disease. Many patients with glaucoma have difficulties in maintaining adherence or persistence to prescribed medication. In a review including studies with objective assessment of compliance and persistence highlight this fact. Using electronic monitoring, over 20% of patients were missing more than 20% of their doses. Data from studies that use prescription records to calculate the proportion of days covered by medication indicated that only 56% of the days in the first therapy were covered. Using prescription records or medical chart review to estimate persistence suggests that 30% to 70% of patients remained persistent on their initial treatment at the end of the first year of therapy. Dr. Nordstrom and colleagues demonstrated that less than half of newly diagnosed glaucoma patients continue to take their prescribed medication after 1 year, and their persistence continued to decline after that. The persistence varies across different classes of medication, which is substantially better with prostacyclin analogs, and patients diagnosed with open-angle glaucoma were more likely to adhere to treatment than suspected glaucoma. We can also evaluate glaucoma compliance in a broader perspective. We all know half of glaucoma patients are not diagnosed, therefore not have the chance to be treated. For those being diagnosed as screening, half of the patients fail to undergo eye examination for further treatment. For patients being scheduled for follow-up, 30% of them did not come back as scheduled. So we have patients who are diagnosed but not treated, or patients who come in but never fill a prescription or loss of follow-up. Then comes what we are focusing today, people who are filling their prescription but not actually use the medication as we asked for. That's also about half of treated glaucoma patients. Finally, there's another level of non-adherence, where patients who are trying to take their medication but not getting the drop in their eye. This is about 25% of people. We all know that non-adherence is a risk factor for glaucoma progression. In a cross-sectional study of 100 glaucoma patients, in which the adherence over a 3-month period was evaluated using electronic monitoring system, Dr. Robin and colleagues demonstrated that patients who were less than 80% adherent had a 7-fold increased odds of having moderate to severe visual field loss. And the result is quite similar when the adherence was evaluated by self-reported confidence in being adherent to glaucoma medication. In the collaborative initial glaucoma treatment study, visual field were taken every 6 months, and adherence was assessed by self-report at the same time point for up to 8 years of follow-up. Among the 306 participants randomized to the medication arm of the trial, there was a dose-response effect where the more doses of medication that patients report missing, the more likely they were to have larger amounts of visual field progression. With this dose-response curve, I think any effort to improve adherence is valuable in slowing down visual field progression. How can we improve compliance or adherence? This slide can give us an overview about how complicated it is in identifying reasons of non-compliance. But it seems to me, points listed in the superior half are mostly related to the social-economic factors or the setting of a healthcare system, which varied across different countries. In Taiwan, we are proud of our national health insurance system, which aims to provide each individual with an accessible and affordable medical care. Also, in this small island, with a well-developed transportation infrastructure, most patients have easy access to the healthcare system at a low copayment. From a personal point of view, Taiwan is one of the countries with the least barrier to health care. However, even with such advantages, the database of our healthcare system show that the persistence to topical glaucoma medication is quite low, only 24% during a 2-year follow-up period. Therefore, probably we need to think from another point of view, the patient's perspective. The health belief model may explain why it is so difficult for a patient to adhere to glaucoma treatment. The model was proposed in the 1950s to explain why people do not participate in screening tests for asymptomatic disease. The theory postulates that a specific health behavior is influenced by a person's perceived susceptibility to the disease, severity of the disease, benefits to treatment, and the barriers to the recommended behavior change. For glaucoma patients, this would mean that the person would only take their medication and return for their follow-up appointments if they believe that glaucoma would cause undesirable visual loss. The treatment offered by their doctor could mitigate this effect, and the barrier to following doctor's recommendation were not so difficult to overcome that they outweigh the perceived benefits of treatment. Furthermore, they need cues to action to integrate taking glaucoma medication into the daily routine. In an asymptomatic patient, if there is no adequate understanding about glaucoma, when facing the adverse effect of medication, no one will be adherent. From the study by Dr. Newman Casey, a report including 119 glaucoma patients, there are at least 11 barriers which are important to at least 1/3 of the patients. And for each patient who's not adherent, usually has their own unique set of issues that's keeping them from engaging glaucoma treatment. To cope with non-adherence, I guess many of you have tried to give patients written instruction about how and when to apply glaucoma medication, or use books and videos for glaucoma education, or even adopt patient-centered intervention for behavior change. However, according to the review, education alone is not effective in improving adherence. A complex intervention consisting patient education, combined with personalized behavioral change intervention, may improve adherence. However, there is insufficient evidence to recommend a particular intervention. Let's take a look at a recent report about the effectiveness of a complex combination of education and personalized intervention in improving glaucoma adherence. The Support, Educate, and Empower Personalized Glaucoma Coaching Program. This program lasts for 6 months and included automated medication reminders, 3 times of in-person counseling, and 5 phone calls. During the counseling, the coach used a web-based tool to generate an education plan tailored to the patient's glaucoma diagnosis, test results, and doctor's recommendation, with a specific aim to identify barriers to adherence and possible solutions. 39 patients with self-reported poor adherence were enrolled in this study. During the coaching program, the adherence improved by 21%, from 60% at baseline to 80% after the program. However, the adherence decreased to 67% at 1 year after the intervention, although it remained significantly higher than pre-intervention level. In another study, the Magic Coaching Program, Dr. Moore and colleagues had similar positive results after an 1-hour personalized glaucoma coaching session with daily medication reminder. There is a 23% improvement in medication adherence compared to the control arm that received generalized eye health education only. However, the adherence decreased over time for both groups and was more rapidly in the control arm. Therefore, we do need a longer-term follow-up to see the effect of intervention in improving medication adherence. Participants of medical trial were asked to list barriers and facilitators for adherence. Interestingly, no matter the patients were classified as low or high adherence, they had similar ideas. The number one barrier is difficult schedule, and the number one facilitator is the smart bottle experience, followed by patient intervention experience. Therefore, to increase adherence, we really need to simplify our regimen, communicate with patients, and select medications with less side effect, or use alternative intervention to reduce medication burden. We all know that adherence decreases as the number of medication increases. In a study from Japan, according to a healthcare database, Dr. Shirai found that after switching from monotherapy to two medications, patients were more likely to be adherent if a fixed combination therapy was prescribed, comparing with unfixed combination. The side effect of a medication perceived by the patient may also reduce adherence and leading to disease progression. As for the barrier in drug installation, Professor Tantisevi and Professor Robin will guide us to understand its impact. Finally, in a busy clinic, what a physician can do probably is quite limited, but can be influential. We need to build effective doctor-patient communication with compassionate. We should build a relationship with our patients, that's mutual trust and emotional affinity, like a partnership between the provider and the patient. We should use eye contact to build trust and to discover nonverbal clues to the patient's understanding and emotion. We should include family members in the communication and encourage technician, nurse to be involved in patient education. And remember to ask patients for questions and listen to them. It is reported that compassionate by a healthcare provider increases adherence to treatment up to 60%. In addition, I like to show my patients their reports. Patients will have a better understanding about the impact of glaucoma on their vision when they are still asymptomatic but the disease is progressing. Through such interaction, we build a stronger relationship with our patients, which can also help them to be adherent and be ready for medication, modification, or further intervention. On the other hand, we need to identify non-adherent patients for targeted intervention. Dr. Newman Case's group found that we can ask a simple question to identify the patients at risk. That is, over the past month, what percentage of your drops do you think you took correctly? If the score is less than 85%, then the patient is likely to be non-adherent. Comparing to pharmacy refill records and complex questionnaires, these sentences have basic correlation with electronically monitored adherence. In conclusion, effective glaucoma management requires active patient involvement. Adherence and persistence with glaucoma medication is crucial to prevent glaucoma progression. A coaching program aiming for personalized intervention, in addition to education, may be helpful for non-adherent patients. We also need to try our best to simplify the regimen, adopt alternative intervention to reduce medication burden, and create an effective doctor-patient communication to help our patients to be adherent. Thanks for your attention.
Visanee Tantisevi, who will share her presentation on difficulties some patients encounter instilling eye drops due to the differences between containers. Visanee is currently an associate professor, vice chairman, and head of human resource and physical management, and head of Center of Excellence in Glaucoma at the Department of Ophthalmology, Faculty of Medicine at Chulalongkorn University. She was also appointed as a glaucoma consultant at Queen Circuit National Institute of Child Health and also serves as a regular consultant at Med Park Hospital. a top-tier private international hospital in Bangkok. She is also the Public Relations and International Affairs Officer for the Thai Glaucoma Society. Her interests not limited to glaucoma, but also in cataract surgery, especially cataract in glaucoma patients, which is always a challenge to her. As a trainer, she has been doing mentoring and participating in glaucoma and or cataract researches, both locally and internationally. She is also a founder of the Interhospital Glaucoma Conference, the academic meeting of the Thai Glaucoma Society for Residents and Glaucoma Fellows. As an expert, she is regularly invited to speak and chair sessions in various national and international scientific conferences, including World Glaucoma Congress, as well as an invited reviewer for many peer-reviewed journals in ophthalmology. Visanee, the floor is yours.
All right. Thank you, Virna. Thank you for a very, very kind introduction about this. This is my financial disclosure. Actually, I do not have any financial interest to any products mentioned here. Well, Dr. Ko just mentioned about what the human barriers about, the adherence and the persistence of the glaucoma patients on using the medication. So now I'm going to talk about the non-human side. So why eye drops difficulties in use is important in glaucoma? Because the topical medication usually is the initial treatment for most of glaucoma subtypes. Persistent and adherence to the glaucoma medication will help on the treatment success or disease control. Well, however, the proper administration of eye drop is something mentioned in the Dr. Kerr's first slide that one of the give the patients of the poor adherence if the proper administration cannot met. Many studies have shown difficulty in the installation among the glaucoma patients. The accuracy or how could one patient can use instill one drop into the eye to reaching the eye, and the contamination if the patients cannot do the technique properly. But I'm not going to do talking about the technique at this moment. Well, the factors that involve for all those things usually mentioned in many, the education, head literacy, aging, visual acuity, or even with the visual field. But anyway, most of all, just as Dr. Goes just said, that the education or instruction how to use the eye drops properly is very important. Well, so as a human, but about the non-human side, how's about the containers? The containers of the eye drops are many, and as usual that we just got, the fluid reservoir, we got top, nozzle, tip, and the cap, and also in the bottle somehow we have the preservative-free bottle that designed for for the multi-dosage, just like in the right part. And yes, of course, varieties in the medication will bring the diversity in their containers because they're from the different manufacturers company. So you can see the many bottles. You can see the for the preservative one, and the preservative free will be in the same design as we call the pipette. So with the different containers, there are some studies that they have some different difficulties for the patient to use all those containers as well. There are some studies that to compare the unit dose pipette with the conventional eye drop bottles to see which one is easier. And this is the study design. They decide with they do with one bottle and one design of the pipette. An eye drop bottle and the single dose pipette were given to the study participants at the same time, and just only with the written instruction were given how to use it, but no assistance at all during the test, and no the patient will use only with the same eye and the same hand, which one that they prefer. The difference of the variables will be assessed in the visual analog scale or the VAS, and these are the variables that assess about the ease and difficulty to open, and the impact of the size on the handling, the shape, whether how it impact on handling as well, the content inside the bottle or or those containers, feeling when the bottle is in the hand, and the ease and difficulty of the drop installation, and the overall impression of the performance or the handling of the dispenser. And you can see here there are the baseline characteristic, and usually the elderly, with most of them, they have no previous experience with the eye drops. Again, all the results, this shows that which of the pipette or the bottle that they favor. It's kind of very similar to what appeared in the meta-analysis, but actually in study, this is not a meta-analysis, but they just, give us some kind of the chart that very easy to look at. And it shows in this, the pipettes were better in the patients in the visualization of the contents on the installation and the overall performance. But if we look into a subgroup of the patients who has prior experience, the pipette was easier to open. But in those without prior experience, the pipettes were easier to install. So by the way, it's very easy for them with the pipette. And for the gender of the male and female, and you can see here the male is fond of the bottles because it's easier for them to open. But whereas in the female, the pipettes were easier to open. And you can see in this study, male has no experience with the bottle, with the eye drops before, and some female had experience using the eye drops. The old study reported that using single-dose container associated with the experience. But for me, maybe it's not just like that, because usually female can do the detailed tasks better than men, and the men can do something just like, as a men stuff sort of thing. So something that rougher with the female. So this is my purpose. That might just only the purpose for me. So in this study, they showed that the unit dose pipettes were easier to use, even though this participant in the study is the elderly, but they are healthy with a good VA and no other systemic disease that might negatively affect the installation of the eye drops. So in this study, it is difficult to predict if this is true in the handicap. Another proof of the containers reflect the difficulties is about the dispenser type. This is a retrospective cohort. They evaluate the medication possession ratio. All right, it's a very, very difficult to understand. But for the study, this anecdotal, the proportion more than 1.2 is overconsumption, with the less than 0.8 is underconsumption. And just compare with the travoprost in bottle and the travoprost in the unit dose pipettes, and the fixed combination, or I would like to say in the COSOP and the bottles before they were taken by the Santen company. It was then with the Mersham and Dome, and you can see the bottle of the COSOP is just like this, and with the pipette and the COSOP COSOP preservative free just in the pipette. This is the equation for the medication possession ratio. Well, and for the results and the conclusion, they just summarized that the bottle type dispenser and the old age were associated with the overconsumption, which means that they have to, the leftover, they use more on the bottles for the very specific time period than in the pipette. And you can see here. So that's why the bottle somehow is very difficult to predict whether the patients will use in the proper time period or the interval before the next change into another bottles. Now, it's a house of when they do the jobs, they have to squeeze. These are the studies that are to show you the force that need on the bottles or the containers or anything that you have to use the drops into the eyes. This is some kind there's just mock up just like this, where that is some bottle, and they start with the force with the initial 600 gram and increment with the 50 gram weights until the eye drop were extracted from the containers. And we found that, and the study found that the glaucoma agents has the highest force to for the installation, just as this. And among the glaucoma types, if we look at that, you can see the least force that used on the glaucoma medication containers appears in the Celatine and the Thermoptic, which is very interesting, and which means that the patient needs not much force on that, and maybe it's much easier for them to put the eye drops into the eye. Anyway, because of the eye drop itself, the eye drop adherence, just mainly we have to obtain the medication at the right time and at the right, into the eye properly. And we need to instill it every day, and how to instill the eye drop successfully. So there are many installation aids produced and introduced into the market for helping on the eye drop administration, because the suboptimal adherence to ophthalmic medications may lead to worsen disease outcome, just as Dr. Ko presentation previously. You can see here a lot of aids, installation aids, just you may have used them before, or you may have prescribed to your patients. But anyway, this is the installation is that they try to list you about what is the obstacle and what is their aims to overcome those obstacles. The aim in this table means that how to reach the eye, and how about the next extension, whether the patient need to do the next extension much or not. Well, in this study, they just proposed that many patients could benefit from this ad if made aware of them. And although limited by publication bias or the review on this study, they said that all but 2 of the ads that evaluated has only 2 that had positive objective and the subjective study outcomes on other installations. And the elderly patients and those with the musculoskeletal abnormality may benefit most from an aid. However, if the many patients are unaware of the poor eye drop administration, the first thing that you have to do, you have to observe them during the clinic visit, and maybe you give the opportunity to educate them how to use the drop properly. So actually, I would like to interview the patients, my patients in the clinic myself. But anyway, I think with the video, I have to put some kind of the English subtitles. So I just carry just only what the patients say to me when they have some problem with the eye drops into this, because somehow they say that they cannot hold the container well, so they cannot do the properly eye drop into the eye. They cannot squeeze because maybe it's too rigid for them, and the drops are too large because perhaps the nozzle and the tip is quite too large for carrying the drops into the eye, and perhaps or somehow the tip is too narrow and no drops at all. And in some containers, they say that it cannot recap, particularly with the pipettes. So that's why it's not convenient at all. So in summary, the adherence to therapy is defined as the degree in which the patient follow the prescribed therapy, and the defined period and persistent describe the time in which the patient failed the prescribed therapy until the first discontinuation. So that's, in get along all together. And because of the glaucoma medical treatment success will usually depends on the adherence and the persistence of the medical therapy, and depends on many factors, particularly with the disease status that needs multiple drugs. And you can see with the multiple drugs, the patients will lose their adherence in some way because it's too many. And the patient lifestyle, and somehow they are in the work, in the working status, and they have to work every day. They might very forgetful, and they don't put any drops at all. And other medical problem like a musculoskeletal, they have the shaky hands, they have kind of the Parkinsonism, and that's why they cannot put the drops into their eyes properly. But another is about the hidden pain point. It's about something, is it a non-human stuff, just like it's the containers that we just mentioned. The different types of the container can cause some difficulties. However, with the pipette itself, the pipette design, it's easier for use than in the bottles in many ways. And with the bottle use, we have to be aware of the overconsumption. However, there are no solid evidence of difficulties using different types of the bottles. Well, I would like to acknowledge my research assistant who helped provide me some of the data and collect the data for me, and for me to get all through this slide to you. And thank you for your very kind attention. Thank you so much.
Thank you, Dr. Visanee and Dr. Ko. Now we will proceed with the next final presentation on the importance of discussing containers with patients. I am privileged to introduce our speaker, Dr. Alan Robin to you. Dr. Alan N. Robin currently holds joint associate professorships in ophthalmology and in international health at the Johns Hopkins University and is also a professor at the University of Michigan. He is a leader in the clinical management and scientific study of glaucoma and was the first executive vice president of the American Glaucoma Society from 2019 to 2023. Dr. Alan Robin was a Heath Fellow and a recipient of 2 NIH-R01 grants, as well as an award from the Glaucoma Research Foundation. He has been an active clinical investigator in initial studies of widely used glaucoma medications, including apraclonidine, latanoprost, brimonidine, brinzolamide, and rokinase inhibitors. He was the principal investigators and developed NDX laser iridotomy, responsible for the development of alpha agonists for clinical use, and performed the first modern prevalence study in India. Dr. Alan Robin has published over 275 peer-reviewed seminal articles on the use of lasers, drugs, and surgery for glaucoma treatments in addition to manuscripts on cost-effectiveness and adherence. Dr. Alan Robin's current research interests include pseudoexfoliation, medical waste, and improving adherence to glaucoma therapies. He is one of the most knowledgeable ophthalmologists on adherence and has won many honors and awards during his career, among them the Senior Honor and Secretariat Awards of the AAO, the Outstanding Humanitarian Service Award of the AAO and the American Glaucoma Society, Secretariat Award of the American Academy of Ophthalmology, and the Silver Achievement Award of the Associate of Ophthalmology and Visual Sciences. Due to the time difference, Prof. Robin recorded his presentation for us and unfortunately unable to accommodate questions from the floor. Please start his lecture.
Hi, good day. My name is Dr. Alan Robin. I'm delighted to have been invited to be with you today, regrettably in a hybrid mode, to talk to you about what I've learned over the last 10 or 15 years about both medical therapy and adherence. If you ever wondered why, in a patient who you follow closely, whose IOPs are always well controlled, but there's progression in their visual fields over a 7-year period, how does this happen? Or have you ever wondered why, in the early manifest glaucoma treatment study, that half of those people who were treated still progressed? Part of the reason for this is the fact that I believe we're oblivious to the fact and we don't pay any attention or ask patients about whether or not they adhere to their medical therapy. I'd like to talk to you about that today. Adherence is a major issue in therapy. If you don't take a medicine or take it incorrectly, it doesn't work the way you want it to. Some lessons we've learned is that 20% of patients didn't see their eye doctor in the 18 months after they were diagnosed as having glaucoma. 40% of newly diagnosed glaucoma patients had not filled their prescription within a 2-month period. About a third of patients didn't persist with their medication at a year, and a half of the patient can't even correctly name their glaucoma medications. This is an example from an asthma study. There was a microprocessor chip in the canister, and it recorded every time the canister was opened and executed. The x-axis is time, the y-axis is how many times it was actuated or the canister was used per day, and the green line is what the patient should be doing. You can see that at the beginning in November, the canister was dispensed, and the patient was pretty good for about 2 weeks, then forgot some applications and used it a couple times more than they should have, about early December, And then from mid-December to early January, they didn't use it at all. They realized their follow-up appointment was coming soon with their doctor, so they overused it and then overused it again. This is something that we're going to talk about at great length. Another slide here is from a gentleman by the name of Virgins who's done work on systemic hypertension. The green horizontal line is perfect adherence. The brown line is what patient actually did because of discontinuation of treatment. And the dotted line is the difference in poor execution in the dosing regimen. And that's a major issue. And you could see that by the day 200, about a third of the patients already stopped their medications, and 10% couldn't take them correctly. So lesson number one, ask patients if they're taking their medications. We sometimes forget to do that. For a patient's perspective, it means they care. The corollary to that is don't believe them if they say they did take it, because they may not have actually taken it. Adherence is different in ophthalmology. We have bottles that people have to squeeze, and we actually have to get a drop in the eye without contaminating it and not getting too many drops in the eye. There have been some very good eye administration in the last decade or so. One of them has been the Travatan dosing aid on your right, which actually helped the patient know if they took the drop, how many times they took the drop. The other one was the Beta-Gan C-cap, which you'll see on your left. And the Beta-Gan C-cap was used to remind patients if they took the levobutanol once a day, whether or not they took it that day. Sometimes you forget whether or not you took your medicine or not. And if you used it once or twice a day, whether or not you took it in the morning. So this was a very important thing. Both of these flopped. And the reason they failed was because the industry wanted to use them to make more money and sell more drug, and it didn't do that. But they were still good ideas. So lesson number two is that different manufacturers of generics use different kinds of bottles, especially in Asia. And different bottles have different rigidity, have more trouble squeezing. You can get more or less drops. So ask patients whether or not they're having problems with using their eye drop bottle. The next issue that we'll talk about is execution. That is the ability to correctly instill the drop in the eye. And by correctly, I mean, does it get in the eye without contamination? As you can see from the first slide here, this is a patient who is 4 days post-op trabeculectomy, and I'll play that for you again. She is just squeezing the bottle and just having no idea of what she's doing. The second slide here is of a lady who's experienced, who's been on glaucoma drops for decades, and you can see sometimes she gets the drop on her nose rather than on her eye. And the other issues, such as contamination and squeezing too many drops, you'll see this was an optometrist mother who was squeezing the drops in her eye. This is the patient who said he had no problems getting drops in his eye, and he instills them so they just get right in his fornix and his puncta. And he's basically doing his own punctal occlusion. We did a study looking at individuals who were experienced with glaucoma medications, who said they had no problems whatsoever and had been on glaucoma medications for over a year. And depending on the bottle type, about 3/4 to 80% were able to get a drop in the eye. Most of the patients, about half of them, contaminated their eye drops. So the lesson 3 is that patients are clueless. They don't know if they're getting a drop in their eye or not. Watch them. Ask them to instill their medications when they're with you. Watch your patient. If they can't instill a drop and have no social support at home to put drops in their eyes, why prescribe drops? Do laser treatment, do a MIGS, do something else. But drops are obviously not the right thing for your patient. We did another study looking at whether or not adding another medicine made a difference. Does 1 versus 2 make a difference? Most people think about adherence as percentage of medications taken. That is, if you have 30 pills for your systemic hypertension, you're supposed to take one a day. If you take all of them, then you have perfect adherence. The problem with that is that if you take all of them on the first day, or if you look at that slide for the asthma inhaler, take some day and some another day, you have too many on one day and no coverage on other days. What you really should be looking for is coverage, which is the proportionate time between intervals of dosing. That is, if you're supposed to take a drop every 12 hours, do you really take a drop every 12 hours? We did this with what are called MEMS containers, but the first person to look at adherence was Mike Cass back about 40 years ago when he looked at eye drop medication, both pilocarpine at that time and timolol maleate. Here you can see his microprocessor in a pilocarpine bottle, and what he did is he put a microprocessor chip inside the bottle, and this was activated every time the bottle top was removed and the top of the container was turned upside down. And we always think that the evening dose, or the the nighttime dose, is the most difficult. Well, it turns out that really it isn't. It's a nighttime dose before you go to sleep. So it's not the afternoon dose, it's the nighttime dose, because people get tired, they forget they've taken it. So if people have trouble with their once-a-day prostaglandin that you say to take in the evening, but they can take it in the morning, tell them to take it in the morning. It may not be quite as effective, but at least they're getting a drop in their eye. We always think of a problem of adherence as being a little too little. They miss their drops, forget their drops. But actually, from Mike Cass's study, we see that 2/3 of the patients took more than 3 drops a day at some point, and about 1/8 of them took more than 3 drops a day for at least a week. This just came out in Lancet. It's an article about a man who was in Germany who was vaccinated, actually in a 29-month period, took 217 COVID vaccination shots. So even today, we can see that people are vaccinated, take too much. So it is a problem of too much too. In our study, we put eye drop bottles in containers, and we measured how many times they took the drops. There were microprocessor chips in the tops that told us if the drops were used. We found out that having 1 or 2 drugs, a prostaglandin or a prostaglandin plus another drug, made a huge difference in adherence. So obviously the people who were poorly adherent were people and used 2 drugs were people who just didn't take the drugs in the first place. It turns out that it wasn't the first drug that made the difference, because there really was no difference on the first drug. It was the second drug that made the big difference. So lesson 4 for all of us is simplify the medication regimen. Make sure that you make it as simple as possible, rather than add, try to subtract and use a different class of medicine. Finally, I'm going to talk about the importance of the doctor-patient interaction. We don't always think about this in what we do, but I think what we do is very important. We did a series of studies looking at doctors and patients when we prescribed medications. Both doctors and patients were video recorded. They both gave informed consent, and the doctors thought it was all about the patients. This was almost 280 patients who either newly prescribed medicines or had medications changed. All these were video recorded and transcribed, and they were coded by 3 research assistants to see what was done. Okay. What we found is that neither at any of the time periods, that is initially at 3 months or 6 months, did doctors talk about how many drops to use, how long they'd be using the drops, the name of the medication, why they're using it, or even which eye they should take the medicines in. Finally, we did a focus group with patients, and we asked them what they wanted to know, and this is what they wanted to know. about glaucoma, what it is, what it causes, how do you treat it, what's my pressure, and about glaucoma medications. They wanted to know how long will they be using it, what the adverse events are associated with them, will the drops make me see better. These are important things, and if you're interested, you can take a picture of this slide or copy it and use this to talk to your patients. Give them little note cards before they see you and ask them to write down 3 things that they really want to know about. This will save you time, will help you educate your patients, and finally, hopefully improve adherence.
Thank you again, Prof. Robin, for setting aside time from his busy schedule to present at the webinar. So, is there any question from the audience? Oh, okay, no question for now. So, for the audience, if you want to ask, you could write down in the chat box or Q&A chat box, and then we will see and we will discuss what is it. So, Dr. Visanee and Dr. Ko, it is very interesting topics actually about, yeah, we know that our patients sometimes, even in my clinic, I could see patient with control IOP, but then when we check with the progression, it is still going on and going on as we could see. So for Dr. Ko, probably first, what will you do if you have patient like this? So how we know whether it is related with the adherence or whether it is related actually with other things. Please, Dr. Ko.
Yes, it's sometimes very difficult to let the patient know how important the adherence is. So every time I have such kind of experience that if I show my patients, show their reports, showing that their disease is progressing, and the next time when they come back, the IOP is much lower than the previous one. So I guess that probably most of the patients are not that adherent unless they know their disease is progressing. So I guess doctor-patient interaction is quite important. And for another point of view, because I have eye care, we have eye care in Taiwan. So sometimes for those kind of patients, I will try to borrow the home care or eye care to them for probably 1 week and to let them make a record to me. So probably I can differentiate whether they are not compliant or probably they really have a lot of fluctuation in IOP. So that's probably the 2 major conditions that I encounter and try to solve these kind of issues.
Oh, thank you, Dr. Ko. And how about you, Dr. Visanee? Unmute, please.
I have to unmute this. Sorry. Yes, and yes, I agree with Dr. Ko. But I think for our side, if the patient comes up at the clinic with the controlled IOP, but still the progression is reviewed, I think there are 2 important things. One thing that do the patients, yes, of course, we have to ask whether they have continual drops management on their eyes, because somehow they just use the eye drop just before they come to visit the doctors, and but actually the doctors can catch up what is going on with them. So but if they or they have some evidence, or they just insist that they do the regular eye drop as prescribed, they have a good adherence and persistence, we have to ask, we have to look for something else. Just like I will ask them about other things, just like whether they are smoking or still have smoked in the past, and then they just quit, and how long they just quit smoking, because I believe the smoking has something on the vascular abnormalities and the autoregulation sort of things. And others just very important. And I just found out it's quite often and often about the OSA, the obstructive sleep apnea, and we have to look for that as well, whether they have some other risk factors apart from the, you know, poor adherence of these patients. And of course, with just kind of the Dr. Ko, just like if all right, okay, if you do not do well with the medications, we have to put you on surgery, we have to put you on lasers, and sometimes the patients might not need that, and they go back with the better adherence to the medical treatment. And that's right. Yeah, might be. That's for me.
Okay, thank you, Dr. Ko and Dr. Visanee. There is one question from Konsiti Mawali. How common is surgery in the event of poor use of medication as an indication in practice? Good presentation. Please, Dr. Maybe first, Dr. Visanee first, then Dr. Ko. How common is the surgery? Is surgery in the event of poor use of medication as indication of practice? So maybe when we choose to do the surgery, because we think that the medication is maybe not properly used. What do you think, Dr. Visanee?
Yes, that's a very good question. Is it that the job is not properly used? We have to talk, at depth and in depth and at length with the patients. What is going on then? And if they, because the adverse events or because of their lifestyle or because of many things, we have to. Get them some other options about the treatment of the glaucoma, whether less invasive with the laser, whether they have the SLT, then could that be could they fit for the SLT and has a good response, or they have to do something else just like a surgery. And we have to look at the type of the glaucoma as well. If they have just kind of the angle closure, how's about take out the lens off? If the patient has a significant cataract, sort of things, and perhaps take just only the cataract off, would that be enough to help the patient on the maintain the good IOP control and resulting in the good disease control, or we need to do something else just like a filling or anything? And we have to talk and discuss with the patients whether they can, which way they could go for.
Okay. And how about you, Dr. Ko? What do you think, Dr. Ko?
Yeah, I think the practice pattern is different in different countries. For my patients, because I think most in East Asia, most patients are very afraid of surgery. So if the patient knowing that they probably need to go to surgery, they usually let me try this kind of medication. I will be more adherent, and we will discuss about the process. So theoretically, we should go to surgery if the patient cannot be adherent. But sometimes you need time to communicate with patient and to let them know completely about what's going on after surgery. So if it's fully understand about what's going on and the potential complication of a surgery, sometimes the patient will be more adherent, but sometimes the patient really opt to have surgery because they think that will have a better disease control and will be better for the long-term outcome in glaucoma. So I think although surgery is really a good choice, but I think now we have other alternative approach. So probably laser or mix will also be good choice. So we should probably offer this kind of choice to our patients, but at an earlier time point, it will be beneficial. Thank you.
Yes, Dr. Ko. Yeah, I think it's in some country, like in my country as well, especially in the very far islands. Sometimes we have to think about early surgery. So maybe the one that Constantine asked is actually related with that, with the um, maybe the because of the place, and then also the not the easy to get the proper medication maybe. And we will have further discussion about this later on. And there is a question from Dr. Chen Benson. Hi to speakers. I'd like to ask your experiences about instilling problems caused by bottles or pop eyes. And how do you educate your patients? Thanks. Maybe this will be first with Dr. Visanee, please, about the instilling problems with the bottles or pop eyes. I don't know pop eyes. I don't have that. Maybe you know.
Sure.
Maybe you know.
I'm not sure what the Popeye is, but with the bottles or maybe the pipette. Oh well, okay. If they have always, there's oftentimes they complain about the bottles, so we have to ask them to show the medication they have been using, and they have how to educate them. All right, okay. Ask them and to show up, and then get them show us about what they use, how they use when they use the eye drops, so we can see what is correct and what is I would not say that incorrect, but I would say that some kind of the need improvement. All right, and to make them uh, get the drops into the eye more properly, and to get the most benefits from all those drops. So, which means that we have to be face to face and let them show you what they do, what they usually do, whether it does correct or not, and then you just show them which one is better for them, and ask them to practice, and then when let them go back to home, and then when they go back when they come back with another visit, ask them to show you again what they do. That's for me.
Thank,
But
thank you,
somehow
Dr.
you
Visanee.
can, yes, you can set up the kind of the glaucoma friends sort of things, and you have the counseling counters that comprises of the nurses or your assistant to help educate the patients about what should they do with the installations. Yeah.
Okay. Thank you, Dr. Visanee. How about you, Dr. Ko? Maybe
Yes,
yeah, short
yes, I
answer.
agree with Dr. Visanee. Let the patient show you how to apply the medication. But for some instance, I do change between different. For example, prostate glanding. Different company have different bottles and different hardness to squeeze the bottle. So for some patients, probably they feel that the bottle is too hard. So I change it to another brand. Or sometimes for a patient, they think the bottle is too soft. So every time when they squeeze, a lot of drops comes out, and finally they get shortage of the medication. So when if you can listen to the patient, ask what's that feeling in instilling the eye drops, probably we can choose a better one for them to accommodate probably their other kind of disease, how their force and their daily activities.
Okay, thank you, Dr. Visanee and Dr. Ko. I think because of the time, we have to end our webinars. I once again thank Professor Yu-Chieh Ko and Professor Visanee Tantisevi, and also Professor Alan Robin for their time today. Also, I thank everyone who tuned in today. As mentioned earlier, you will receive a short survey to provide your feedback on this event. Only after completion will you receive a certificate of attendance. Your participation will help us improve on future professional development offerings. Before we end, we again thank Beatrice for its support towards APGS educational endeavors. And in 2 months, the Asia Pacific Glaucoma Congress will be held in Manila, Philippines, from May 24 to 26. Please join us in the Congress. We will discuss more depth about glaucoma. And then APGS is on YouTube, and we encourage you to subscribe and set your notifications on so you can be updated on our online content. This concludes our today Asia Pacific Glaucoma Society webinar. Have a wonderful day or evening, depending on where you are. You may now disconnect. Thank you so much.
Thank you, and thank you everyone.
Thank you. Thank you, everyone.
Thank
Have a good day.
you. Thank you. Have a great day.